بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد صلى الله عليه وسلم وعلى آله وصحبه أجمعين. It is my pleasure to be with you tonight in the third wave of the international peer list. And tonight this wave addressed by nutrition and growth. And our pleasure to be in this night, Dr. Flavia Indrio. Dr. Flavia. Dr. Flavia?
Yeah. Hello, everybody. Hello, everybody. Good evening to everybody. It's a pleasure for me to be here. Hello.
And we also, you tell me you love Egypt. You love Egypt, Dr. Flavia.
Yeah. I had a beautiful experience last year in Pedia Egypt Congress, and I wish I could come back when all this story of COVID ended and we will be free again to move all over the world. So,
welcome, Dr. Flavia. And Dr. Flavia is the professor of pediatric, senior consultant of pediatric gastroenterology in the Department of Pediatrics, University of Bari, responsible of the pediatric gastroenterology and the motility unit, teacher of pediatric gastroenterology and nutrition for the resident in Pediatric University of Bari School of Medicine, tutor of for medical students at University of Bari School of Medicine, and the active member of the Committee of Nutrition ESPGHAN and the e-learning program for ESPGHAN. It's our pleasure to be with you, Dr. Flavia, and nice to see you tonight. And also we have Dr. Yasmine. Dr. Yasmine. Dr. Yasmine. Dr. Osama. Dr. Osama El-Asheer. دكتور أسامة.
زنون أنا معاك دكتور زنون.
ازيك يا دكتور أسامة؟
ازيك يا دكتور زنون؟ How are you?
It is nice to see you with the beautiful face and beautiful smiling.
Yes. Thank you, Dr. Zannun. Welcome, Professor Flavia. Good evening, everybody. I'm actually. It's a pleasure for me to be with you in Egyptian Academy of Pediatrics in a very interesting conferences they do. And firstly, I'd like to thank Egyptian Academy of Pediatrics for the great effort they do for continuing medical education in this difficult period, actually, where medical education cannot be done because of limitations and quarantine due to COVID. But actually, Egyptian Academy of Pediatrics succeeded to fill this gap by doing these very nice and very interesting webinars. And actually, they succeeded to choose elegant speakers in every webinar they do. So I congratulate my dear brother, Dr. Muhammad Zannun and Dr. Wael Bahbah for this great success. Hoping for more and more success, inshallah.
Dr. Osama El-Asheer is the professor of pediatric and pediatric clinical nutrition in Assuit University Hospital. And now we leave the floor for you to moderate this session, Dr. Osama, and we hope to a good and beneficial session for all pediatricians, especially the young one. And we do the best to this webinar in the best way, inshallah.
Thank you, Professor Zannun. I'd like to welcome you again. Welcome, Professor Flavia. Welcome all audience present with us in this very special day, which will be a very interesting day for all pediatricians and specifically for all who are interested in clinical nutrition like me, because actually today we have two stars as a speakers 2 stars in the field of pediatric clinical nutrition. Professor Flavia, a star from Europe, and Professor Yasmine Gamal, a next star from Egypt and the Middle East. I'd like to, it's a pleasure for me to introduce Professor Flavia. Dr. Zannoun said that Professor Flavia is one of the elegant speakers, actually. Myself, I'm very interested in her lectures. I attend the lecture for her last year in Egyptian Academy of Pediatrics. Professor Flavia is a consultant of pediatric gastroenterology, senior consultant of neonatology, University of Bari, Italy, and she have special interests in pre and probiotics. So we are interested and a very active member in European Society of Pediatric Enteral and Parenteral Gastroenterology, Hepatology and Nutrition, ESPGHAN. So we are interested for listening her talk. Welcome, Professor Flavia. You can start.
Yeah. Good evening to everybody, and thank you for this nice word about my presentation. And even if, as Dr. The chair introduced me as an expert of prebiotics and probiotic, the talk of tonight will be the failure to thrive. That is a very practical issue where during our clinical practice we daily handle this. So let's start with the definition. The failure to thrive is a chronic, potentially life-threatening disorder of infants and children who fail to gain or may even lose the weight. So children are considered as failing to thrive when their rate of growth does not meet the expected growth for a child of their age. And more specifically, the term characterizes those whose weight is below the 3rd percentile on appropriate growth chart. So this is the book definition. And also is a term, failure to thrive, that is used to describe an inadequate growth or the inability to maintain growth in childhood. And this is very frequent. So we are not going only in a strict definition, but we have a wide range of application of this definition. So attained growth when the weight is below the 3rd percentile on a standard growth chart. When the weight is weight for 8 ratio, it's below 5 percentile on a standard growth chart. When the weight in 20% of the weight or more is below the ideal weight for 8. So it's a ratio between weight and 8. And also when the rate of growth is less than 20 grams per day from birth to 3 months of age, but this we will see later, less than 15 days from 3 months to 6 months, fall off from previously established growth curve, and downward crossing of the 2nd major percentile. Okay, this is the definition, classical standard. But let's go to this very famous chart definition. So we said weight below 3rd percentile, that is this, the lower, for more than one measurement. So it's not enough only one measurement, we have to take it again. When the decreasing weight that cuts 2 major percentile lines over time. What this means? When we have a child on 50 percentile and over time it just falls down to the 3rd. When the weight is less than 80% of the ideal weight age, we have the line here, the weight and the age. And when the weight is below the 3rd centile compared to the statutory age. But this is a mathematical calculation. Population is very wide, society, population change. So look at this picture. That's myself on the arrow. When I was to the nursery school, and look at this, all white children, all, you know, Caucasian race. And look now, this is a classroom of one of my daughter when they were young. White, yellow, Chinese, Africans, Caucasian. So how can this chart just fit in all this kind of population? So actually what we really do need are specific growth chart for specific race. For instance, any Vietnamese growth chart will be totally different from the black that have a standard that are totally different. So we do need to understand very well the frame where to include these children. Moreover, if we stand with all these parameters I showed you before, we have a possibility to make a lot of mistakes because we can use unsuitable materials, for instance, some weight proof that are absolutely not working. We can use an inadequate growth curves, like we are using a black one for a Vietnamese. We do not consider a birth weight, like the small for gestational age. When we have a failure to evaluate the genetic target, that is extremely important, and when we have a failure to detect any dysmorphism. Moreover, it's extremely important whenever we want to include in that growth chart the evaluation of a seated head or the lower upper segment ratio, the head circumference evaluation, then the evaluation of evident sign like dysmorphism, faces, eyeline, hypertelorism, low attachment of the ears, and of course, short fingers, alteration, some fingerprints that make us thinking to other possibilities that are not just a failure to thrive. And as I told you before, we have the average weight increase a day that is totally different in the age. We have the higher growth during from 0 to 3 months, because during this period, the baby had to double the weight of the birth. So the children just increase their weight like from 26 to 31 grams per day. And this is decreasing 3-6 months, 17 to 18, until 4 to 6 years of age, that is 6 grams per day. This means that we cannot wait a child of 4 years of age every week or every month. We have to wait to understand if there is any possibility to change percentile or a decrease of the rate of growth, at least every 3 to 6 months. So no meaning to go every month or every week when the baby is older than 1 year. Moreover, it's important also to understand the height velocity, because failure to thrive is not only up on the weight, but also on the height. So the average of the length and the height velocities is again the maximum, not from 0 to 6 months, but it comes, look at this, during adolescence, during from 12 to 24 months of age. So we have to keep in mind that again, the length is important. We cannot just take the length of a newborn every week or every 2 or every second weeks, because then we have to wait to measure only 1 centimeter, and this can be disoriented. So we have, again, the length should be taken every 3 to 6 months. And of course, we have the height velocity very high after in the 2nd year and the 3rd year of life. Once we get all these parameters, we go to the etiology of the failure to thrive. And as you can see, 20% only is due to organic causes, and the 80% of the causes of failure to thrive is non-organic. What exactly means? What means organic? What means non-organic? So we have the organic cause of failure to thrive, basically one that are settled on prenatal age, like prematurity, maternal malnutrition, in utero exposure to toxic agent, alcohol, smoke and drugs, infection, IUGR, and chromosomic pathology. What are the organic causes of failure to thrive postnatal? So we have the inadequate caloric intake, the inadequate absorption, increased caloric requirement, excessive loss of calories, and altered growth potential of regulation. These are the bigger chapter where we can include all the disease we can look during the organic cause of failure to thrive. But please keep in mind, these are only the 20% of the cases. That means that every 10 children we visit for failure to thrive, only 2 will be included in this. So just have a look, because these, of course, are the more severe, the organic, and we do need to make a diagnosis properly. So the inadequate caloric intake could be due to an incorrect formula preparation, neglect, excessive juice consumption, especially during toddler age, poverty, behavioral problem affecting eating, non-availability of food, misperception about diet and feeding practice, and error in formula reconstitution, that is like the first one, incorrect formula preparation. Moreover, we have a dysfunctional parent-child interaction and child abuse or neglected. This is kind of a mix, organic and non-organic. Behavioral feeding problem, mechanical problems with sucking, swallowing, and feeding, primary neurological disease, chronic systemic disease resulting in anorexia, food refusal, and neurological problem. So we have a possible inadequate absorption. And look at this, a very severe disease, but that we have to think about this. So cystic fibrosis, celiac disease, vitamin deficiency, and hepatic disease. When we have an increased caloric requirement, so the baby is not growing because it's not assuming an adequate caloric requirement. When we have a hyperthyroidism, congenital heart disease, chronic immunodeficiency, chronic respiratory disease, neoplasm, or chronic recurrent infection. So a lot of possibility to include in our differential diagnosis. And when there is an excessive of loss of calorie, when there is a persistent vomiting, when there is a gastroesophageal reflux or a gastrointestinal obstruction, when there is an increase in intracranial pressure, a renal losses, diabetes mellitus, of inborn error of metabolism. So basically all pediatric pathology included in this. And what are the last altered growth potential of regulation? Of course, chromosomal abnormalities and endocrinopathies. And what are the causes of inorganic or non-organic functional failure to thrive? So these are more due other than medical causes. So poor feeding skill on the part of the parents, dysfunctional family interaction. This is very typical. Remember, 80%. Difficult parent-child interaction, lack of social support, lack of parenting preparation, family dysfunction such as abuse, divorce, child neglected, and emotional deprivation. So we have to look to this during our history. So how can we do diagnosis? First of all, perinatal history. Let's go to look for gestational age, for IUGR, for small spot gestational age. Once we are got with this perinatal history, we go to the nutritional history. And these are the questions that we have to ask the parents. How many feedings per day is having the baby? And how much milk per feeding is the baby fed? And how is the formula prepared? And how is the total caloric intake account? So we can make account, just a diary. In what position are the baby breastfeeding? If he has sucking difficulties, or if he's refusing the bottle on irritability. And then we have to go also to familial history. When and where the baby eat? Who do the baby eat with? Who is taking care of the baby? Are there any family stressor? Economical problems, mental illness, depression. Unfortunately, being a pediatrician, we became the consultant of all the family, and we have to perceive completely what is going on around the baby, because this will help us to make the diagnosis, especially during this failure to thrive issue. So this is an algorithm. So we start. It's inadequate caloric intake. So we say, if the baby introduce less than 100 kilocalories per day, then we have to increase the calories. If it's not working, then we have to look for other causes like otitis, UVI, and other diseases. If the baby introduce 100 calories or even more, then we go to a possibility to understand if there is an inadequate absorption. So we check for vomit, diarrhea. If we have vomit or diarrhea, then we just get oriented on the IPLV, cow milk allergy, sorry, this is an Italian acronym, gastroesophageal reflux, cystic fibrosis, post-infectious disease, or celiac disease. If there is no vomit, no diarrhea, then where is the inadequate absorption? Maybe in the defect of use, maybe in an increased metabolic consumption. And so we have to look for genetic disease, metabolic disease chronic disease and endocrinological disease. And so we go step by step to understand and to get oriented in the diagnosis. After we make the story and the diagnosis, we just step on the laboratory test. Of course, we do blood tests to understand, to get oriented on the disease, like electrolyte, CBC, liver function, immunoglobulins, thyroid, glycemia. Of course, stool test to see if there are fatty acid or fats that are losing in the stools, and urine analysis and urinoculture just to understand if there is any infection. And then after we get this first step, we go to instrumental tests like the karyotype, the skin prick test, the sweat test, pH impedantiometry, and even do gastroscopy if we are oriented on celiac disease. But this is the scenario that's happened to us. When a mother goes to the doctor because the child is not growing. And this is the question. She is very demanding. The doctor has to tell me why the baby isn't growing. Hopefully it's not a serious thing. And he must test the baby for all the investigation. I want to be sure that my baby gets the precise diagnosis. And these are the questions that the baby processes. So why am I here? And I hope you will not give me blood test because I just want to escape of this. And these are the thoughts of the doctor. So look, how can I get rid of those people just coming all over and over again? And those people are crazy. I have to explain all over again. And moreover, maybe I'm missing some real severe disease. So do I have to perform the test? Do I not? Do I have to concentrate? This is a very typical scenario that happens in our daily practice. But we have to take some example to understand. So I bring some experience that happened to us in our laboratory. So this is a growth chart. Look, this is our university. This is a baby, age 12 weeks, okay? And he weighs 4 kilograms. We go to the normal chart and we found the baby below the 3rd percentile. So red alarm, red flag, the baby is a failure to try. But if we just use the correct age, then we have that the baby, 12 weeks, it's with the correct age because he was premature. He was born 32 gestational age. So we cannot use this, but we have to use the correct age. And then suddenly the baby jump on the 25th percentile. How it's possible to evaluate the correct age? We have the chronological age minus 40 minus gestational age in weeks. And after we calculate the weight for the correct age. So we precisely can include the baby in a precise calculation of the weight. Be aware that on the baby that are born small of gestational age, if we're just keeping them feeding and feeding and feeding because we thought that they are below the 3rd percentile, we have a high risk of obesity. And this is another example. So the baby is called Eduardo. Look at this baby. His weight and age was always below. Well, this is the 8 below, always on the 3rd, and suddenly this comes from the 25th percentile below the 3rd. And so Eduardo, had this until he was a very first weeks of life. So we have absolutely to consider is the cow milk allergy. And then we can have the two possibility, IgM mediate, non-IgM mediate. So we have to go for this immediate hypersensitivity, gastrointestinal hypersensitivity, or oral allergic syndrome, allergic eosinophilic esophagitis, allergic eosinophilic gastritis, protein-induced enterocolitis. And I want to go back again on this chart because look at this. There was no jump on the weight, always a very, very difficult grow on this baby. So something chronic. So we have to think, especially if we have other signs, we have to go to look for the cow milk allergy. And look at this. We have a baby that is growing nicely until 4 months of age. And when he starts the weaning period, so he introduced solid food, and in Italy they eat, carbohydrates like micro pasta for the child, we do have very, very tiny pasta for the baby, then suddenly the chart goes from the 50th percentile below the 5th. In this sudden, and especially during the period of weaning, we have to think to celiac disease. So we have to interpret this course, but I think Professor Yasmine will talk about this in the other talk later. And this is something that I really like, because this is belonging to the non-organic, and this is something that happened, at least to my practice, several times. So we have a baby 1 month. So the baby cries, arches, regurgitates, detaches from the breast, maternal despair. So the mother comes, I'm desperate, I want my baby that is not feeding. So first pediatric consultation, not in the gastro department, of course. They stop the breastfeeding. So they change the formula, they start ranitidine, they put the mother on diet because they were thinking of a cow milk allergy. So the baby still crying and regurgitate. So again, maternal despair, I'm desperate, baby is sick, he will going to die. So several pediatric consultations, several formula changes until they reach to the PPI. So they give to those babies just because they had this. Look, there is this decrease, but what's happened was all during these 3 months, from 1st to 3rd months of age. So baby still crying and regurgitate. So 4 months, hospitalization, laboratory test, pH impedantiometry, X-ray, transit time, gastroscopy, all negative. After this, free diet and weaning, and the baby start again to grow. So this is a very typical example of non-organic failure to thrive, and how it's absolutely not necessary to go to all these tests if we don't make a history, and especially a familial history. So failure to thrive can be very different. Look at this. She is Brooke. She weighed 8 kilograms. She is 76 centimeters, but is 16 years of age. And this is Talil. His weight is 9 kilo and 100 grams, 17 centimeter, is less 900 grams if we compare to the age, but it's 10 months and is healthy because it came from Ethiopia and it was evaluated with the Italian growth chart. But the Ethiopian is a race that are much smaller than the Italian. Talil now is absolutely an healthy child. So what is the conclusion? That failure to thrive is a descriptive term, not a specific diagnosis. So it's a result of inadequate usable calories necessary for a child metabolic and growth demands. Simplified approach of failure to thrive, but detailed history, please detail history through physical examination with primary caregiver, initial investigation, only blood test and urinary analysis, and then also stool sample. Trail of nutritional therapy with calorie dense diet. So I thank you very much, and I hope to meet you in person, inshallah, in Egypt. Thank you very much.
Thank you very much, Professor Flavia. Thank you very much for this very illustrated and very comprehensive talk. Before introducing Professor Yasmine, we have just 2 to 3 questions till preparing Dr. Yasmine. Firstly, the first question, when we can say this is a case of malnutrition, and when we can say that it's failure to thrive?
Well, there are, of course, when we consider a malnutrition generally, there is not only weight and age. Then we have to take other parameters for nutritional assessment. So we have to take the fat. We have to take other parameters to speak about malnutrition. Weight and age just allow us to make failure to thrive. So we have to make other parameters.
Yes. The second question about growth charts. The WHO growth charts are already multi-center growth charts from different countries.
Yeah.
We need to do specific charts, like you say, for Vietnam, for Mediterraneans, or the WHO can do this in a spot?
No, the problem is, you know, that even, for instance, we do have in Italy the Italian growth chart. But now in Italy, there are a lot of immigrants come from all over the world. And I show you the example of Talil. He came from Ethiopia. And they are very thin and they are not so very tall. So he came to us, say it's 900 grams less. But we cannot have for instance, in Italy or also in Egypt, you have a lot of people come from other countries. So how can you just evaluate? We have to consider this and just try to understand that we cannot compare, for instance, the Vietnamese that live in Italy with the Italian growth chart, but the Italian pediatrician cannot have all the chart for all the population. So we have to use common sense in this, but we have to consider.
Yes, thank you. The last question before introducing Professor Yasmine, about the minimum duration that should we continue complete nutritional supplement, then shift to regular formula or regular feeding?
No, I didn't get. Can you repeat it?
Yes, about the duration to use high caloric formula.
Sorry.
Then return to regular
high caloric formula, you have to use it when, for instance, we have some specific circumstances, like we have the Crohn's disease, or we have a baby who is not feeding properly, is not taking the correct amount of calorie. So we use the high amount of this high density calorie formula. And once we get the growth at the standard rate that we want, so we can stop. But we have to follow the baby. So it's not limiting the time. It's the baby who should tell us when to stop. When we reach this gain weight in a normal weight velocity, then we can stop. But there's no limit, no time limit.
Yes, you said that if he crosses 2 centiles, it's considered to be a failure to thrive. And for avoiding obesity, just to cross 2 centiles increase in weight, I stop nutrient dense formula or continue till 15th percentile?
Until 15th percentile. Until the 15th percentile, the average.
Thank you very much. We will return again for you in Q&A after lecture of Professor Yasmine. Now it's the time to introduce my dear colleague. It's a great pleasure for me actually to introduce my dear colleague and dear sister, Professor Yasmine. Professor Yasmine is a professor of pediatric clinical nutrition. I said firstly that we have two stars as a speakers today. The first star from Europe, Professor Flavia, and the second star from Egypt and Middle East, Dr. Yasmine, one of the elegant and eminent speakers in pediatric clinical nutrition, not only in Egypt, but in all the Middle East and Arab countries. We are all interested in her knowledge, and she is one of the very competent team of clinical nutrition in Shams University. And I'm actually honored to be one of the students of this team at a time.
Thank you, Professor Osama.
They have their friends, actually, Professor Sana Yusuf, Professor Ab Khairi, Professor Yasmine. They have their white fingerprints on our unit in Assuit University. And we are usually keen to be within Shams unit for more and more advancement of our unit. Professor Yasmine, welcome. And we are waiting for your interesting lecture as usual. Welcome, Professor.
Thank you, Professor Osama, for this introduction. Really, it's too much. It's an honor to be here amongst all the doctors. It's an honor to be with Dr. Flavia, an eminent international scientist in gastroenterology and nutrition. Actually, she's the Northern Star because she covered everything regarding failure to thrive, growth charts, growth. And I always like to discuss growth assessment because it's the basic that a pediatrician can do. And it is the one cornerstone that can prevent malnutrition that we are facing, especially in our country. So I will start sharing my presentation.
Okay.
So it's clear.
Okay, it's clear, Dr. Yasmine.
Okay, so I'm discussing children growth, assessing the norm, which is a really basic step. Everybody thinks it's basic, and it's done in every clinic, it's done in every hospital, it's done in every primary health care center. And if it's done properly, we are preventing malnutrition, yet we are having an alarming rates of malnutrition in our country. So what is going wrong? This will be answered in this presentation. Why should we assess the growth, the parameters, interpretation, the difference between the growth charts, when to measure, and the clinical implications? Why we are highlighting this, why we care so much about growth assessment and early prevention of malnutrition? Because we are dealing with the first 1,000 days, the first 1,000 days, which are the cornerstone and the foundation for bringing up a healthy generation, a healthy environment for our children. If the nutrition in the first 1,000 days is right, you are having a healthy adult with good programming, with no metabolic disorders in the future. Children with healthy nutrition in the first 1,000 days from pregnancy till the end of the second year are 10 more times to have better immunity and less likely to have infectious disease. They're having more IQ, they are more productive individuals, they earn more wages as an adults, and they are more likely to have healthier families. A lot of research recently in the last 10 years about the impact of healthy nutrition with the right protein and the right calories and the proper growth assessment will lead our generation, our children, to be healthy adults later on. So we are dealing with the foundation of life. Malnutrition, on the other hand, is the biggest contributor to child mortality, whether it's from pneumonia, from diarrhea. Malnutrition brings a heavy burden because if the child is malnourished, he's more likely to die from other infectious disease. The Lancet states that malnutrition, the consequences in the first 2 years of life is irreversible. What happens, what is done. Cannot correct this. Children with malnutrition in the first 2 years of life will have less IQ, less cognition later on. The immunity is compromised. The programming, the risk of diabetes, cardiovascular disease, and obesity later on is compromised. A lot that can happen in these 2 years. Malnourished children grow up with worse health, lower educational achievement, lower wages, less productive adults in the community. Josette Chiran, which is a vice chair, World Economic, he's a businessman, okay? So when a businessman discusses something, there's a huge impact, money, there's money. If the child in its first 1,000 days from conception to 2 years does not have adequate nutrition, the damage is irreversible. So what happens in the first 2 years of life is irreversible. We have to prevent any defect, prevent anything that compromises our children's health. Okay, so what is growth? Growth is a dynamic process, and in children, growth has 3 specifications. It's ongoing. You cannot stop growth. It is not acceptable for any child to have a stationary weight for 6 months, stationary length for 6 months. This is not accepted. When a mother comes and telling me that the previous year we will have been on the same weight, this is not acceptable in children. It is normative. We have normal ranges. We have normal growth curves, and it is expected. I'm expecting the child who is born with 3 kilograms to triple his weight at the age of 1 year. I'm expecting growth velocity. I'm expecting him to reach the growth curves, his potential. Of course, we have genetics, external, internal factor that can affect growth. Yet, growth is a dynamic process. It is not allowed to be stopped in any way. We have different growth patterns, whether it's the general growth pattern, which with 2 spurts, the infancy, the growth spurt of infancy and the growth spurt of adolescence, whether it's the brain and head growth, the brain growth, which happened maximum in the first 3 years of life, completed at the age of 5 years, and the rest is functional maturation. So brain growth, if it's not ideal in the first 3 years of life, the demise is irreversible and is long-lasting, lifelong. The lymphoid tissue growth, which is maximum at the age of 10 years. And of course, we have the reproductive growth, which occurs at adolescence. We have, of course, some systems that are retain the capacity for hyperplasia throughout the life, like the skin, GI, epithelial cells, and the liver. Okay, and the neuronal division is completed by the age of 1 year, maturation at the age of 3 years of the brain, and it is complete at the age of 5 years. So we have a spurt in the first year of life that is not matched in our life later on. Rapid body growth, the weight triples in the first weight of life, the body length increase by about 50 to 55%, head circumference 40%, and the brain weight doubles. The micronutrient needs are more 10 folds vitamin D than adults, 6 more folds of iron needs than adults, vitamin A, more needs than adults, zinc, energy. So the needs are really huge because the spurt is really huge. We have to match the needs and we have to match the spurt with the adequate needs, or else I will have stationary growth that will end faltering growth and then malnutrition. So we are pediatricians before being a clinical nutrition, and the pediatrician first role is to prevent malnutrition. Growth monitoring is important to detect deviation from the normal early in the course of life, identify malnourished children, identify children who are at risk of becoming malnourished. Screening is really important in hospitalized children. Screening in outpatient clinic and primary healthcare setting is really important. Use just a lot of screening tools are now available for pediatrics, from the NutriStep to the Strong Kids to the PIMS, the Pediatric Yorkhill Malnutrition Score, to the STAMP. A lot of screening tools. Just use the simplest one that applies to your practice and use it, because early having bad scores, 4 to 5 in Strong Kids. We use the Strong Kids in our hospital, Ain Shams University Hospital. Strong Kids has proven in research to be the easiest screening tool. Screen if they are having bad scores, 4 to 5. Early intervention is the key. Why we are discussing malnutrition: short-term impact, lethargy, irritability, decreased immunity, high morbidity, mortality rates. The child who is borderline, who is not malnourished, he's a borderline child, will have shock gastroenteritis more quickly than other children, will have complications of pneumonia rather than a well-nourished child. So even borderline is not accepted in children. Long-term delayed neurodevelopment, behavioral cognitive deficiencies. Children with iron deficiency anemia in the first 2 years of life were reported to be aggressive adolescents and were reported to be imprisoned more. This is research, evidence-based, that we are dealing with, that we have to prevent malnutrition in our community, and of course, decreased immunity. So what are we doing wrong? If we know that prevention, an ounce of prevention is better than cure, what are we not doing right? Why our children are faced with malnutrition? In Egypt, we're facing a huge burden of malnutrition, stunting around 24%, iron deficiency anemia around 50%, wasting around 8%, and we are not really having progress in this field. What can go wrong? Failure of documentation is number one. In our country, we don't have patients. They go to primary healthcare settings and they go to private doctors and they doctor shop, as we say. So every documentation is different. Improper gross charts use. We have a lot of charts in the market. We have the CDC, the WHO, the Egyptian gross charts. Which chart should I plot the child? And every visit, I should plot the child on the proper gross chart. Inaccurate anthropometric measurements. And this is really sometimes really confusing to the parents and to the doctors. I measure the height of the patient and it's 100 centimeters. And then she tells me, doctor, did he lose height because he was 104 centimeters in another clinic? So the inaccurate anthropometric measurements, and these few centimeters can shift a child on the curve from undernourished, from being on the 3rd centile to being on the 10th centile, really can have huge impact on assessing our patient and the need for intervention. Inadequate dietetic history. We don't have time to take dietetic history, labored dietetic history regarding breastfeeding, regarding complementary feeding, 24-hour recall, the feeding environment, the feeding behavior that the child is doing, failure to prioritize nutrition care, lack of screening, and inadequate nutritional education and training. The faces of weight issues that we are dealing with children, whether he's malnourished, whether he's obese, whether he's a picky eater, are a lot with children, and it all starts with the success recipe. Proper assessment, anthropometric evaluation, proper gross chart selection, interpretation of this gross chart, and monitoring of our patient. So let's meet a common scenario. Omar is a 16-month-old boy. His mother is coming for follow-up visit and checkup. She reports he's not gaining much weight in the previous month. She's worried because she measured his weight in 2 other settings, different settings. On asking about his dietetic history, he was exclusively breastfed for 6 months. After that, complementary feeding was started. Now he eats only 1 meal, restricted to 3 types of food. He's still breastfeeding 3 to 4 times per day. Weight is 10.2 kilograms. Length is 76 centimeters. So in assessing Omar, and with this history, can we interpret, we plotted Omar on a gross chart. So what do you think? Is there a problem with Omar? Should we worry? So you're voting. So Mr. Abdurrahman, yes. Should we worry about Omar? He's plotted on the gross chart around 50th centile. He's 16-month-old, 10.2 kilograms. Should we worry? Yes or not? Okay, a lot said no, we shouldn't worry. And about 43% said, yes, should we worry? The question is, why should we worry? This is the chart of Omar from birth till now, 16 months. So he was a perfectly normal child, 3.4 kilograms. He ended up 1 year, 10.2 kilograms. And he was on 85th centile, and he's just decelerating in the weight, and he did not cross the 50th centile yet. So can you call this? What is your interpretation? This is a normal pattern of growth, or this is failure to thrive or faltering growth? Please vote. Okay. Normal pattern of growth and some reported failure to thrive. Well, failure to thrive has a lot of definition, as Professor Flavia said. Omar did not cross 2 major centiles, yet his weight velocity decelerated a little bit, which is expected in breastfed infant after the age of 1 year. Yet we are facing red flags with Omar history, especially because he's tending to be a picky eater, just choosing 3 or 4 items of food. And we have red flags about the feeding behavior and the feeding in children, especially from 1 to 2 years of age, and the interpretation of this being a feeding disorder later on, a picky eater later on. So this is another lecture with the feeding disorders, but we have to interpret Omar growth patterns. Really, he's not yet failing to thrive, but we have to monitor him really closely. So the components of anthropometric assessment. Omar was his mother was worried because she had multiple weights in every clinic. The key is standard equipment, standard technique. Anthropometric measurements are operator dependent. There may be false, taking the equipment may be false, or we are not using standard techniques in measuring anthropometric measurements. Standard equipment for weight, using a digital scale. Using digital scale is better than using a beam scale or using a coiled scale, because they have to be calibrated every now and then. The child has to be without clothes or with a clean diaper. If the child is above 2 years, he has to stand on the scale with minimal clothing, without shoes. So this is standard equipment, standard technique. Normal variation at a given age of weight is wild. Infants are measured nude with minimal clothing, and we have to measure them every month in the first year of life, every 2 months during the year, every 3 months thereafter. And we have a growth velocity, which is important, like we had in Omar's case, gaining about 30 grams per day in the first 4 months, making about 750 grams per month. The next month, about half a kilo. The last 4 months, about 250 grams per month. Then we have to have realistic expectation to the mother that growth is expected to be 2 to 3 kilograms from the first and second year. And it's not allowed to be more actually, or less, because more, if we gain more, half a kilo in each year before the age of 5, we will end up in an obese child later on. So we have to monitor the growth velocity very carefully. Sometimes we deal with equations. We have a very famous equation that is taught to us in our pediatric curriculums, that the expected weight is age in years times 2 + 8. This equation only applies to 1 to 6 years children, and it is a rough estimation of weight, and it's not that accurate. The second component is the height or length. Length less the recombinant length less than 2 years, height more than 2 years. Of course, it's an index of chronic or long duration malnutrition, and it is the maximum growth potential. Children above 2 years of age are not allowed to gain less than 4 centimeters per year. If this happens, this is a compromise of the height velocity. And we have to have, of course, standard equipment, standard technique. Recombinant lengths are measured by the infantometer. If I don't have an infantometer, I can just use a piece of wood and calibrate it as an infantometer, 2 cardboards, and the child has to have 3 main cornerstones: the head in the Frankfurt plan, the knees are straight, you have to straighten the knees because children have the tendency to flex the knees below 1 year, and flat feet against the board. If the child is less than 2 years, he can't lie down. Length is the height plus 0.8. So if I'm measuring the height in a child less than 2 years, because the charts are plotted according to the length, if I'm measuring the height, I have to subtract the 0.8 centimeters. We had a lot of videos on the WHO site about the standardization of the measuring techniques. Measuring the length, you need 2 operators, one to strengthen the knee, one to strengthen the head, to straighten the head and straighten the knees. So a lot of videos to teach us how to properly take anthropometric measurements. This child is not, of course, measuring his length. The knees are not touching the cardboard. He is not in the Frankfurt plan. He's taking a photo. Children above 2 years, we can use the stadiometer. The stadiometer, standard technique that the child will stand in the Frankfurt plane as well, with the head, the occiput, and the shoulders, the buttocks, and the heels touching the stadiometer. Take care, because we have these scales in our clinics, and they can sometimes harm the child's eyes or the child's face. So the stadiometer is the standard, and we have, of course, a velocity increase in the stature, which is really important above the age of 2 years to measure the stature of the child and the velocity of height. And this was already covered by Professor Flavia. We have to get the mid-parental height to know the expected height, and if the child is in the growth curve that is expected for his age. And we have to, there are a lot of calculators, we can calculate it, online calculators. They're just getting the projected adult height and putting the child centile, his height in this centile. The weight for height, which is a good indicator of malnutrition. If it's less than 75%, then we are dealing with severe malnutrition. Head circumference, up to 5 years. Do not measure head circumference before 36 hours of age. When the child is born, he has some edema, so don't measure it before 36 hours. And it is useless after 5 years because the brain size is complete. No charts for head circumference after 5 years of age. We just have to put it between the supraorbital ridge and the occipital prominence and just plot it on the chart. And of course, we have a growth velocity for the head circumference as well. Mid-arm circumference is an underlooked anthropometric measurement in our society, yet it's very good in screening for malnutrition because the WHO uses it for screening in villages with malnutrition. We have the midway between the shoulder and the elbow, and we measure it with a Shakir's tape or just a regular tape. If it's more than 13.5 centimeters, this is adequate nutrition. Less than 12.5 centimeter, this is frank malnourished. If it's 12.5 to 13.5, this is borderline. It is really useful, mid-arm circumference, in patients who cannot be weighted, in critically ill patients, in patients with edema, in patients with solid tumors. So correct weight assessment cannot be done. Mid-arm circumference helps us a lot in this domain. BMI, of course, is the preferred measure of adiposity, and it's effective measure of adiposity after 2 years of age. It is the weight over the height in meters squared, and all children should be screened for their BMI at 2 years of age, because if they are reaching the 75th centile, there is possible risk of overweight, and we have to put them in prevention plan at the age of 2 years to prevent obesity later on. Of course, from the 85th percentile to the 95th percentile, this is risk of overweight, and above the 95th percentile, this is obesity. This is the time schedule where growth assessment should be taken for children, bi-weekly in the first month of life, then every month in the first year, then every 2 months in the second year, and the mid-arm circumference starting from 6 months. And it's more or less a non-age dependent parameter of growth assessment. So I need you to vote. We have all these growth charts in our country. They are available all over the world. The CDC 2010, the WHO 2006. We have our Egyptian curves, and we have the UK WHO charts. And I will tell you in a while why did I mention these charts. So which one are we using? Please vote. Okay. Yes, the majority in our country, we're using the WHO 2006. It's a multi-center study done covering all the continents in the world. It describes how should a healthy breastfed infant really grow. Why we're not using the CDC, we'll mention why we're not using the Egyptian curves, and why we're not using the UK WHO charts. And I mentioned them because a lot of us now are discussing the NICE guidelines regarding faltering growth, and their cutoffs are really different from the WHO cutoffs, because the UK WHO charts have different cutoffs regarding malnutrition, regarding the centiles, and the guidelines are based on the growth charts. So we can use the NICE guidelines regarding the management or the assessment of the patient, yet we cannot use their cutoffs regarding definition of faltering growth or failure to thrive. So optimum growth is the 50th centile, the median of growth. 50% of the children are growing or having this weight at this specific age. And so long as the child growing are within and parallel to the growth chart from the 3rd to the 97th centile, this child is a normal child. Whether he's on the 15th centile or the 85th centile, he's growing in his own curve, he's growing parallel and within the curve, he's doing fine. What is the difference between WHO growth charts and CDC growth charts? Why we're not preferring to use the CDC growth charts? Actually, the CDC on their website, they recommend the use of the WHO growth charts. The CDC had a mixed population of formula-fed and breastfed. The WHO was only in breastfed infants and toddlers. They really show us how children should grow, and it's standard rather than a reference. It was multi-center, covering all the continents. So it more or less in Africa, it was in Ghana, and in Oman in Middle East. So it is representative of how children all over the world should really grow. So what's the problem if I'm having the CDC chart? I'm plotting my child on a CDC chart. The problem is on the CDC charts, the children are heavier. So if I'm having a perfectly normal WHO chart and the child is perfectly normal, or the 3rd reaching the 15th centile, if this same child was plotted on the CDC chart, the child would appear really malnourished with an intervention plan that he does not need. So the assessment would be different, and we would go to a pathway that is not really needed for this child. What about our Egyptian growth charts, which was done by Professor Aziz Ghali in 1999? They represented a lot of how should Egyptian children grow, yet the growth charts should be updated, and we have secular trends in growth. So unless our charts are updated, really there's a change and the shift in the growth for children. We have to update our charts so that they could really represent our population. So far we're sticking to the WHO growth charts. These charts are downloaded actually from the CDC sites, and it is written on the chart, a CDC chart, yet it is adapted from the WHO. So this is a WHO chart that is downloaded from the CDC, which recommends using the WHO charts in the first 2 years of life. And take care of the cutoffs, because the cutoff of the WHO chart is the 2nd and the 98th centile. The cutoff of the CDC gross chart is the 5th and the 95th because these are different cutoffs. Beware when using gross charts that recombinant length to standing height measurement difference is approximately 0.8 centimeters. So the length is more than the height by 0.8 centimeters, and the charts are adapted to length in the first 2 years of life. Optimally fed study population to a reference population using the general pediatric population we have the difference in cutoffs. We have different also scales of measurements. When to use the percentiles, I'm discussing the percentiles till now, and when to use the Z-scores, which the WHO-based is definition of malnutrition on Z-scores, and when to use the percent of the median, and what's the difference between them. So the Z-score or the median, it's an observed measurement minus the expected measurements over the mean standard deviation. So the 50th centile is equivalent to the 0 Z-score. Every centile that is less is -1 Z-score, reaching -2 Z-score, which is the cutoff for malnutrition, whether it's in weight, height, weight for height, and above is +1 centile, +2 centile, and these are the equivalent. Why use them? They are more precise. If we all begin to use the Z-scores, more accurate management, describe our patient when they do not fall within the gross chart percentile. If I'm dealing with a patient that is less than -2, less than the 3rd centile, and he's somewhere there, I cannot follow him up. He is still less than the 3rd. Maybe he's improving on a nutrition plan, and I don't know if he's improving or not. So the Z-score here comes really beneficial because he can be -2.9 Z-score. And with improvement or intervention, he's now -2.5 Z-score. The follow-up after 1 month, he's -2 Z-score. So my patient is improving. If I'm just using the percentile, I'm really not accurate of my patient. Z-score, it seems to be complicated, but the calculations is really simple. We can have the calculator on our mobile. This is a calculator from the mobile. It's the stat gross charts, the EPI-Info nutritional stat that can be downloaded on the computers. The stat gross charts on the computer, really comprehensive. The mobile is the easiest way. We all use it in our clinics. We can have the Pedi tools at home, and we just enter the date, the weight, and the height, and the centile is calculated, and the Z-score is calculated. The benefit is when we have a cutoff of -2, especially in the height for age, this may need further assessment or further endocrinal assessment. This is the key to the WHO gross chart. The green shaded area is the safe area. This is the 50th centile, 0 below 1 is still green. The height for age less than -2, he is stunted. The weight for age less than -2, he's underweight. The weight for height less than -2, he's wasted. And the BMI, he is wasted as well. If it's -3, this is a severe condition. And the possible risk around the 75th centile, overweight above the 85th centile, and obesity. So this is the definition of different malnutrition according to the WHO. Let's meet another case. Ahmed, a 1-year-old boy. His mother came to the outpatient clinic concerned about his weight. He weighs about 12 kilograms, 1-year child. Length is 70 centimeter, and occipital-frontal circumference is 50 centimeter, which is normal. So this is his weight on the WHO weight for age centile, and this is his height below the 3rd centile on the WHO length for age for boys. This is his head circumference, which is normal. What's your provisional diagnosis? Is this child obese or overweight? Please vote. Okay. %50%. Actually, the definition of obesity and overweight is really tricky in children under the age of 2 years. And it's really about judging the weight for height rather than definition of obesity or overweight in children less than 2 years. Regarding his length, Ahmed is stunted, normal, or wasted. Okay. Yes, definitely. Ahmed is stunted. which doesn't go really with his curve. The weight and the height curves should go hand in hand together. If the child is on the 97th centile for weight, his height should probably be 1 centile more, 1 centile less, then the centiles should go together. If he's stunted and his weight is really increased, then this child, the appropriate next step would be weight reduction, remove cereals from the diet, or endocrine consultation. So what should Ahmed do? Yes, definitely. A stunted, obese child would really need endocrinological consultation. Okay, there's a glitch here. I don't know why the presentation is not moving. Yes. So what about premature kids? Professor Flavia had a lot of Italian growth charts, okay, but the wonderful thing about growth charts, they are a universal language. We can understand the growth trajectory on a growth chart, whether it's in Italian or it's in Egyptian or it's in English, so it's more or less all interpretation. A premature child, Amal, a 10-month-old, born at 32 weeks gestation, the length at birth 38 centimeters, the weight 1.4 grams. Her parents came concerned that she's much smaller than her peers, and they believe that a healthy weight at 10 months is 8.5 kilograms as judged by the growth charts, or they checked it on the internet. So this is Sama's chart. They plotted Sama on the chart, and she's less than the 3rd centile. Do you think she has a problem? Yes or no? Please vote. So Sama is less than the 3rd centile. She needs complete nutritional support now. She needs a complete nutritional plan. Yes or no? Okay. Okay, I'm really disappointed from this answer, because it was discussed with Dr. Flavia about the plotting of premature infants. Okay, so according to this growth chart, I'm plotting Sama just according to the chronological age. She seems to have a problem, but should we plot Sama on a special growth chart of a premature growth chart? Yes or no? Of course, yes, because then her growth would dramatically change. We can either use the Fenton growth charts, or we can use the intergrowth, which continue on the WHO charts done by the WHO team. So the intergrowth 21st, they can be downloaded. The Fenton chart can be downloaded, or we can correct her age and plot her. She's 32 weeks gestation. She cannot be plotted before she's 2 months old. And when she's 2 months old, a correction of age, she will be corrected. Sama's gestational age, we plotted her according to her gestational age. Sama appeared to be a normal child, growing normally along the 3rd centile, more or less. So she doesn't have a problem. She doesn't need intervention. She just needs close follow-up. So changing just correcting the age has changed the decision that we are taking regarding this child. We have also to highlight that special children need special charts, like Soha, a 4-year-old with CP. On assessment, she has delayed milestones. She only sits supported. Her anthropometry, she's 4-year-old, 14 kilograms. Height couldn't be assessed because these children, sometimes they have contractures. And the tibial length, we measure their height by the tibial or the knee height or the tibial length. And from an equation, we can anticipate the height. On the WHO, her weight was less than the 3rd centile, but on her growth charts, she was really doing fine. Special growth charts for cerebral palsy, they are based on the gross motor function classification system, how she moves. Okay, so choosing the right chart and choosing the right classification system, then plotting Sama, she appeared to be on the 75th percentile. Her weight for her age, so she's fine. She doesn't need support. She's doing fine. She just needs follow-up. When growth deviates from the normal, when we have normal deviation from the normal, check accuracy of your measurements. As we said, standard equipment, standard technique. Check your equipments. Note that individual growth may not follow a smooth curve. Sometimes children they lose. The most important is that they catch up and regain what they have lost. Recognize limitation of a single growth percentile value. Velocity is what really matters, not a single value. As we said, as we met Omar, at first he was on the 50th centile, which appeared to be normal, yet he was steady when we measured his growth velocity. Obtain serial measurements, and the weight for length is less than the second or more than the 98th. We need more history, more assessment, and more evaluation. When should we worry? What are the red flags? Faltering growth, failure to thrive, crossing 2 major centiles. We have to stop, reevaluate, take proper history. The most common cause of faltering growth is nutritional, really inadequate nutritional intake. As discussed by Dr. Flavia, the organic causes of faltering growth, they comprise about 10%. 90% are non-organic causes, whether it's in feeding environment, feeding behavior, assessing the intakes correctly. So this is a symptom that we have to stop and reevaluate, take proper history, and do a proper plan. This is the malnutrition consensus statement from the ESPGHAN. They have the same cutoffs for malnutrition. What is really important is the weight gain velocity. If it's less than 75% of the norm, it is mild malnutrition. Less than 25% of the norm for expected weight gain, severe malnutrition. Weight 5% is mild, 10% is severe malnutrition. Deceleration in weight for length or height Z-score, decline of 1 Z-score is mild nutrition, and decline of 3 is severe malnutrition. Inadequate nutrient intake, this is why we should have a history. I take from the parent 24-hour recall if the child is above 1 year of age. If he's taking 50 to 75% of his estimated requirements regarding calories and protein, this is mild malnutrition. If he's taking less than 25, this is severe malnutrition. So it's not only about the assessment of one point or the assessment of one cutoff, it's about the velocity, the loss, the deceleration of weight, and the intake. Respect normal variation. We have genetic, short stature, short parents, not cross percentile. They grow in their own percentile, normal bone age, normal puberty, genetic target size according to the projected parental height or projected adult height of the child. Constitutional, initial drop in the centiles, they have delayed bone age, delayed puberty, yet we really recognize constitutional short stature by taking proper history because it runs in the family. We have to discuss this with the father and the uncle, and if this happens in the family, they end up with normal height to their peers and delayed growth spurt yet normal final height. Interpret trends, no catch up after initial loss. A child growth chart crosses 2 major centile. Sharp incline, decline in the growth lines. Stagnant or flat line is a red flag. Weight centile, 2 centiles less than the height, red flag. Weight or height centiles less than the 2nd or the 5th. This is really the red flag that we have to assess. Okay, so we have to end this. We have 3 patterns of growth. If the patient is losing weight more than he's losing height, the weight is compromised at first, as we see in the growth chart, then the height would follow after the weight has declined for 6 months and the head circumference is normal. This is most probably malnutrition of organic or non-organic etiology. This is a nutritional problem. If we're having the weight and the length, both are compromised, and the head circumference is normal, think endocrinal cause, think bone dystrophy, constitutional short stature. If we're having the 3 centiles, weight, length, and head circumference compromised from the beginning, less than the 3rd centile from the beginning, then think chromosomal, think metabolic, or severe malnutrition. So we have 2 questions just to make sure that everybody is on board. This growth chart, this is the length of the child, this is the weight of the child. So please vote. What do you think, this growth chart? This is a normal catch-up, constitutional short stature, overweight due to excessive cereals, or a normal breastfed baby? Please vote. So we're seeing the weight and the height both at the 5th, and they are increasing more or less like each other. So this growth chart, if I'm seeing this growth chart, this is what Okay. This is not an overweight child. This is a normal breastfed baby, because both the weight and the height, they are going parallel, the same centiles. So this is a normal breastfed baby. Sometimes they tend to be overweight, then they fall in their own curves after 1 year. So what about the second curve? Okay, this is the length is around the 3rd centile, and the weight is really deviating. Please vote. This is normal catch-up, constitutional short stature, environmental failure to thrive, or growth hormone deficiency. Okay. Yes, definitely. You are right. This is environmental failure to thrive. This is nutritional failure to thrive. The weight is affected, then the length or height will shortly be affected. So to sum up, we have to have right parameters, right growth charts, right statistics, and we have to search for the etiology via taking a really complete history, and to prevent the outcomes of malnutrition and improve the quality of life of our children. Dietetic history is really important. Determine the cause of faltering growth, plot on a proper growth chart, calculate mid-parental height, know where the child is going, consider testing. If there is, if it's not nutritional, if it's organic, consider further testing, appropriate referral to specialists when needed. Always look at the big picture. History, history, history is the golden key. Proper charts, physical exam and labs. Thank you for being with us.
Thank you very much, Professor Yasmine. Very practical and excellent talk as usual. Very interesting charts, very interesting cases. I'd like to insist on a very important point in your lecture is the presence of specific charts for Down syndrome and for cerebral palsy, because many of physicians diagnose these patients as underweight and giving more and more nutrients till being obese, which will add more burden of obesity and presence of subnormal mentality. Thank you very much, Professor Yasmine, and we are going to start questions now. Professor Flavia.
Hello.
Yes, welcome, Professor Flavia, welcome. Now we will start questions. We have hundreds of questions actually from all parts of the world, and we need to still to tomorrow to complete these questions, but we will select.
Hello, hello, Dr. Flavia and Dr. Yasmine.
Hello, Professor Zannoun.
Hello. Very, very, very interesting lectures. And deep thanks to the Professor Flavia and Dr. Yasmine for this scientific value of this day. أنا بس عاوز I would like to announce for the activity through this week. Please. أنا في الأول يعني طبعا أنا عاوز أشكر الشركات اللي بتسبورت معانا وبتعمل لنا دعم بصورة مستمرة خلال عمل الويبينارات، وفي شركات كتيرة الحقيقة برضو يا دكتورة ياسمين ويا دكتور أسامة بتروح وتوجه البروتكشن، حاجات البروتكتيف ديفايسز وحاجات زي كده اللي بتوزعها سواء في العيادات او على المستشفيات او مستشفيات العزل. ومن هنا الحقيقه بنتوجه برضو بالشكر لشركه ابوت نيوتريشن على الدعم، والحقيقه ان هم حاسين قوي بالناس، وفي ظل الظروف اللي احنا فيها دي رخصوا الفورمولا بتاعتهم 20 جنيه، ودي حاجه يعني مقدر لهم، ونقدر ونشجع الاتجاه ده. واي شركه اتمنى في الاوقات العصيبه دي انها تحاول تقلل الكوست على الناس فعلا يا دكتور اسامه ويا دكتوره ياسمين مش مستحملين، مش يعني فاتمنى ان الشركات كلها يعني تحذو نفس الحذو زي ما بيقولوا. انا مش هطول عليكم، بس عاوز اقول بس ان احنا يوم الاثنين اللي جاي ان شاء الله عندنا الاندوكراينولوجي بيرلز ويف 3، ودي اللي هتبقى موجود معانا الدكتوره رشا طريف. طبعا الدكتوره رشا طريف علم وبروفيسور بيدياتريك والبيدياتريك اندوكراينولوجي في عين شمس يونيفرستي. والويبينار كله هيتكلم على الديابيتس، يعني هنخوض في الديابيتس بشكل عميق تايب 1. معانا برضو استاذتنا الدكتوره بسمه عبد المعز وبروفيسور اوف بيدياتريك اند اندوكراينولوجي في المنيا يونيفرستي، والدكتوره امينه عبد الوهاب برضو بروفيسور اوف بيدياتريك اند اندوكراينولوجي في السويس كانال يونيفرستي، وبرضه الدكتوره دعاء خاطر الحقيقه اللي هتكون مشرفانا، وهي هتبقى الموديوريتور بتاع الويبينار بتاع يوم الاثنين اللي جاي. الدكتوره دعاء خاطر طبعا هي استاذ البيدياتريك اند بيدياتريك اندوكراينولوجي في الالكسندريا يونيفرستي. كمان يوم الجمعه اللي جاي ان شاء الله هنبدا رحله طويله في البلمونولوجي ويفز، اللي هنتكلم على البيدياتريك ريسبيراتوري ديس اوردرز، وويف كامله هتتكلم على الكوف ان تشيلدرن. many thanks for you and you can leave now for your discussion and question.
Thank you, Professor Zannoun, for announcement. Thank you. And now we are going for starting the questions. The first one for Professor Flavia about the type of lipid present in milk formula. Is there any rule for presence of medium chain triglycerides in the milk formula?
Presence of
medium chain triglycerides.
Medium chain triglycerides. Yeah. Of course, the short chain fatty acid or the medium chain fatty acid are extremely important because they have facilitate absorption. So these are extremely important to be present, and this could be also a chance to reduce this failure to thrive, especially in the baby who have decreased calorie intake. So because they have a high calorie density, but you can have it in short quantity. So it's important that they are present into the milk.
Is there a certain limit for presence of or certain percentage of medium chain triglycerides?
I don't remember exactly now what is the percentage of the medium chain fatty acid in the milk. I don't remember so far now.
Thank you.
Here are the standard formula requirements, and they are required also. I don't remember now.
Yes, we can take the answer of Professor Yasmine also in this question about the presence of medium chain triglycerides in milk formula of Yasmine.
Medium chain triglycerides is really beneficial in a special formula for special medical purposes, especially children who have malabsorption or they are not able to intake the standard formula, because the standard polymeric formula always remains the golden standard in supporting patients with malnutrition. So if he's having any GIT compromise, medium chain triglycerides, if he's having a hepatic disease, MCT in the formula really adds in the liberation of energy and supporting the patient.
Yes, because they provide many formulas now for our hospitals which are rich in medium chain triglycerides. So many asking this question. The second question for Professor Yasmine about from Dr. Khalaf Girgari from Iraq. He is regular attendee for all lectures of Egyptian Academy. He asks about nutrients.
Welcome, Dr. Khalaf.
He asks about nutrients that can boost the immune system, especially for children, especially in the period of COVID-19.
Okay, boosting the immune system in the COVID, really, we have a lot of debates, a lot of protocols about the prophylaxis or the prevention or boosting the immune system. Let us have one thing clear. If the child is deficient, you have to supplement the defective micronutrient. If he's iron deficient, he has to be iron supplemented, vitamin C deficient, vitamin C supplemented. If he's not taking the intake is compromised, his nutrient intake is compromised, the child has to be supplemented. Whether it's vitamin C, zinc has a role, and a lot of studies have proven it beneficial in boosting the immune system. So zinc supplementation, vitamin C supplementation, vitamin E supplementation. And being a clinical nutritionist, I always tend to supply our children in the context of their diet. So if they are covering the variety of diet, no need for supplementation. If they are defective, or we need an extra push, so we can supplement them with immune boosting vitamins.
Thank you. Very illustrated answer. The second question for Professor Flavia.
I found the percentage of medium chain fatty acids.
Yes.
So in the formula, they can go from the 20, we can find different
40.
formula. They can go from 5% until 40%. So
Yes.
very wide range. You
Yes.
can
Very
find
wide
in a different formula, you can have it from 5% to 40%. This is a review that has been published in the US.
Okay,
So,
thank you. The second question for you about when we should proceed to investigations in a patient with failure to thrive.
Yes, first of all, as I told you during the during the talk, we have to have detailed history. So we have to go to detailed history, especially the familiar one, to exclude the non-organic. When we have some suspicious, as I show you, when we have this drop during the weaning, then we think of celiac disease. When we have always this low with other signs, we think to cow milk allergy. So we have to find some, let's say, red flag or some drop of the weight that allow us to make laboratory test, but especially we have to have more than one evaluation in the time. We have to have more time to evaluate the baby, at least twice. We have to see the baby for 2 times in 2 or 3 months, and to see if this is just continuous or if it's just random, it's just something that happens. So we need to follow more than one visit and find the red flag. And then we are allowed to do, and especially familial history is extremely important to exclude this non-organic, because the environment, psychological, environmental is extremely important.
Thank you. Professor Yasmine, Dr. Medhat Al-Arabi, my dear colleague, Professor of Nutrition at Assuit University. Thanks, many thanks for Professor Flavia and Professor Yasmine. Actually, many thanks from all parts of the world about the very interesting talks. Dr. Medhat asks about factors that affect especially height with normal weight and the nutritional intervention to improve height in those patients with or those children with normal weight, but decreased height. Professor Yasmine?
Okay, height, the problem in height velocity, and we have a problem in Egypt regarding stunting. We have really high rates, is nutritional deficiency, and it's not lack of proper assessment of height early intervention, because it's an indication of chronic malnutrition. It means that the malnutrition, if it's malnutrition, it's more than 6 months that we're facing that affected the height of weight affected first, then the height. We also have other causes, familial short stature, and we have endocrinal causes of short stature that really represent a good percentage. And we have a great publication by Dr. Wael Bahbah that was just published recently that attributed the genetic short stature in Egypt is around 12%, which is a really high percentage. So we have to properly assess the child. If it's familial, if it's constitutional, according to the gross chart, we have to get proper intake. We have to do, if the nutritional intake is compromised, supplement the child. Some studies, they say that the stunting in Egypt is due to zinc deficiency in Egypt, where sometimes when giving zinc supplementation, we have better growth velocity in 6 months or so, 2 or 3 more centimeters than expected. So we have to cover all the aspects of short stature.
Thank you.
So, Professor Flavia, if you have anything to add.
No, I'm absolutely agree with you.
Professor Flavia, about the use of stage 3 formula concomitantly with nutrient-dense formula at the same time, stage 3 and nutrient-dense formula?
In the baby with failure to thrive?
Yes, at the same time, or use one of them.
No, only one of them. If you use the high density caloric formula, why do you have to use two kind of formula? I mean, if you have these children that is like after 1 year of age, that is have problem, you know, for feeding, and you use the high density caloric formula, you no need to use the formula 3, you know.
Thank you. Professor Yasmine, is there any rule for adding flavors to the formula? Can it affect
the acceptability of the child?
Yes, acceptability, the taste.
If this child has to take an oral nutritional supplement to support the growth or to calculate the defect in the calories in the nutrition plan, and it's supported by an oral nutritional supplements, a lot of children, especially children who are picky eaters or feeding difficulty, they have sensory food issues, and they can be improved by just changing the taste of the oral nutritional supplement. So taste has a role in the acceptability of the oral nutritional supplement in the whole support of the nutrition plan.
Thank you. Professor Flavia, about failure to thrive. Till which age we should continue the baby for failure to thrive?
At which age we should continue?
Till which age? The age.
ONS, the oral nutritional supplement.
Yes.
No limitation. I mean, until the baby, well, when it's generally the more critical age is until the baby's got 5 to 6 years of age, 7 years of age.
Yes.
Otherwise, you can have other possibility to increase the calorie.
Till becoming normal.
Yeah.
Professor Yasmine, another question about cutoff points for mid-upper arm circumference for diagnosis of failure to thrive or malnutrition.
Failure to thrive is a symptom. Measuring the mid-arm circumference, as said, it could be used as a tool for screening of malnutrition if the child is less than 12.5 centimeters.
Okay. Professor Flavia, another question about failure to thrive versus faltering growth. Is there any difference between the two terms?
No, it's just a matter of denomination. It's the same.
It's the same. Professor Yasmine, another question about balance between protein, carbohydrates, and fats in the milk formula, a nutrient-dense formula. Balance between these ratios, especially in picky eaters.
Yes, this is a really good question, because sometimes we're faced with problems when children with faltering growth or children who has a defect in their growth, sometimes the doctors give them protein supplements, for example, just extra proteins added with extra load on the kidneys, protein that is not calculated according to their age. And these supplements are marketed to enhance the growth. What is really important is the calories and keeping the balance of the protein being at least 15 to 20% of the total calories, the carbohydrates at least 50%, and the rest are healthful fats. So keeping this balance is really important. In whatever supplement that we are giving the child, it's not it's not just giving modular products. It's not just giving excess carbohydrates or giving excess proteins. They will not work in a plan to support the child nutritionally. So we have to give a complete plan with a normal balanced ratios of the macronutrients and micronutrients, of course.
Okay. Professor Flavia, about body composition scales can be used in pediatrics?
Of course, it's important to have the composition of fat, well, the amount of the fat, but we are now then going on obesity, or if we are going in severe malnutrition, that we need also to have the composition of fat more than the muscle. So, and the subcutaneous fat, definitely. But just if we are in these two kind of disease, like malnutrition or obesity.
Thank you, Professor Yasmine. I think you have a body composition scale in Enchams University, or you are using
Yes,
just
we're
scale?
using
Yes.
this because it's only evidence-based above 5 years, and the cutoffs, we have cutoffs for the fat mass and the fat-free mass. So we're using for children above 5 years in assessing the muscle mass especially, and it helps us a lot with the children with obesity, because we don't want them to lose the muscle mass and support them earlier. We also have a bariatric center for children, and the body mass composition is done weekly for them to ensure that they don't lose a lot of lean body mass. So it helps a lot, the body composition, yes.
But not less than 5 years of age.
No, it's I don't know if the literature reports that it's really effective in less than 5 years. Maybe Dr. Flavia can elaborate on this.
Say once again.
About the body mass composition analysis in less than 5 years of age.
Less than 5 years of age?
It's worthless. It's worthless.
Yes.
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 It's totally worthless.
Okay, question for Professor Flavia about what is the type of immune deficiency developed in case of failure to thrive or malnutrition?
In immunodeficiency?
What's the type of immune deficiency developed in malnourished children? SB cell, T cell, or combined?
Yeah. I think I read this question in this
Q&A, yeah.
Yeah. But
From
I
Dr.
really don't understand. I mean, which kind of type of immune deficiency in malnutrition? It is cellular or immunoglobulin? Generally, it's mixed.
Both. It's both.
Both. It's mixed.
Both.
Because yes, you have a low amount of protein. Well, you have, hypoproteinemia. That is, it's making shortage of immunoglobulin, and you have a totally disrupted balance of mucosal, intestinal mucosal immunity, and you have a decrease of cellular immunity. So you have a mixed one.
Yes, it's mixed type of immune deficiency, both in the gut and the Professor Yasmine, another question about are we need in Egypt for screening for children for presence of failure to thrive or malnutrition?
Okay, screening is the first step to detect malnutrition in children. So we have to have a screening for every hospitalized children, for instance, and in primary healthcare settings, children should be screened to detect children who are at risk of malnutrition early, so we can do early nutrition intervention for them. So yes, I would recommend screening.
Yes, you prefer which type of screening? We hear many lectures
there are a lot of tools
about a lot of screening parameters that can be used or modules that can be. Which one do you prefer?
Well, we had an experience in El-Asheer University Children's Hospital with the strong kids, which worked fine because it's really easy and it's quick, and it can be done by the nurses or the residents, or it's really easy. And we had another experience with the PIMS, the Pediatric York Malnutrition Score, which was a little bit detailed and need a proper assessment. So it was overlooked by the nurses, and it was really not done regularly. So we had a publication about the strong kids, and it worked effectively. Screening needs to be simple, and it needs to be quick, and it needs to direct us to decision making.
Yes, especially strong kids, taking in consideration the type of disease and severity of illness. So,
Dr. Flavia, do you use the screening tool in Italy?
Yes.
Which screening tool do you prefer?
For malnutrition, you mean?
Yes.
Well, I have to be sincere. We have only some severe malnutrition due to disease. We don't have malnutrition for shortage of food, of neglected children. We have a very spread social system, and generally the baby that we handle with malnutrition are babies that have a severe disease like short bowel syndrome or others. So no
You
there
don't
is
have
no
this burden in
reason
the community.
for us to,
Yes.
yeah, I have to be sincere. It's, you know, very spread control of the population. And we have in Italy, all the children all over Italy get a pediatric consultation for free anytime they want, ever, always, every time. So yeah, for free. It's paid by the government.
Okay.
So not any children get in malnutrition except if they belongs to a vegan family or, you know, because they just decide to not go. But we have a very strong social system. For instance, they go at school and the teacher are aware of this. They call the social service or the police and everything is settled immediately. So it's no matter for us to go.
It's not allowed.
They're not allowed to go like us. Okay. So Professor Flavia, I'd like to ask a second question about the body mass index. When we can use body mass index, the age to be used in spite of weight and height charts.
The body mass index, it's a parameter, but I want also to know what Professor Yasmine think about. It's to evaluate obesity or, you know, not more malnutrition, but yeah. So we have to use it when we are dealing with obesity. I don't know, but maybe
above 2 years, yes.
And we can use it whenever we want to diagnose obesity and the grade of obesity.
Yes.
Okay. Another long question from Professor Nagla Sami, Professor of Pediatrics at Assuit University, about failure to thrive associated with immune deficiency, also speaking about in chronic diseases as rheumatoid, about use of nutrient-dense formulas for patients with chronic illness. Professor Yasmine.
Okay. Chronic illnesses, the organic part of the faltering growth or the failure to thrive really have to be dealt with early and effectively, because these children, any chronic illness is associated with increase in the energy requirements. The child is in a catabolic stage, the resting energy expenditure is increased, and the intake of the child has a chronic illness is usually compromised. So the child is anorexic, and on the other hand, the demands are increased. So this is where I see an oral nutritional supplement would fit in the plan. Oral nutritional supplement can support about 50% of the caloric needs of a child in the nutrition plan in really 2 cups throughout the day. And usually the chronic illnesses will end up with faltering growth and with a nutrition compromise. So early intervention with oral nutritional supplement is really in place here. I don't know if Dr. Flavia
I agree with Professor Yasmine totally.
Another question, Professor Flavia, about the use of appetizers in children.
No, we strongly discourage this. You know, we strongly discourage this because they are based on central nervous system receptor, and this long-term use is just having the side effect that goes to directly not eating anymore. So yeah, they're like amphetamine.
Yes, yes. Many parents actually pushing the doctors. We need appetizers. We need to increase weight. We increase.
All the parents need appetizers
except
for the kids.
Presence of normal weight.
In Egypt, we don't have the central nervous system stimulants. We don't have the cyproheptadine. We don't have the appetizers in the Egyptian market. Yet we supply them with multivitamin preparation. Sometimes it's just the deficiency of iron that causes the anorexia. Sometimes it's the deficiency of the vitamin B complex that causes the anorexia. So supplementing a vitamin B complex with iron and zinc improves the child's appetite, and this is the perfect appetizer for me.
Yeah. Also in Italy, we was out of label. This cyproheptadine was off label since maybe from 10 years back, 10 years back. So
we don't
it's not
have
available
it either,
in the market. It's not available anymore.
A question from Professor Yasmine about when to use that score and when to use weight to height charts, or to use both of them.
Okay, when to use percentile, when to use z-scores, and this is we usually as pediatrician we find percentiles more comforting. I think the chart is in front of us. We plot him percentile. Z-scores allow more precision. They are more accurate, and the definition and cutoffs of underweight or stunting that I have to evaluate this child for stunting is a cutoff with a z-score, -2 z-score for height for age. So it's really simple to get the percentile and the z-score. As I said, in a mobile application, the stat growth charts can be downloaded on the mobile. They can be on your laptop. So it's really easy and simple, just standard techniques, standard equipment, proper anthropometric measures, and plotting them on the charts and getting the centiles and z-scores is really easy.
Okay, a question for Professor Flavia about can cow's milk allergy lead to severe malnutrition?
Could be if it's not diagnosis, not severe, but malnutrition, not severe, but yes. If it's not diagnosed, and if your baby still, yes, we can have malnutrition.
Yes, another question also for you about the use of preterm formula. When we use preterm formula and how long?
The preterm formula is to be used to the preterm.
Yes.
That's it. And they have to be used until the baby is discharged from the intensive care unit, generally when the baby reaches 2.5 kilograms. That's it.
Then we continue with regular formula or post-discharge formula?
In some country we have the post-discharge. In some other, generally we use after 3 kilograms of age, we go to the standard formula. 3 kilograms of weight, sorry, we go to standard formula.
Yes, I think there is a recommendation of ESPGHAN that post-discharge formula can be used till 9 months of age. I think there is a recommendation like
it's very old. This was not a position paper, was a review, and it's old about the post-discharge. Could be used, but I'm not using it because I don't like this high amount of protein into this post-discharge formula, and so I strongly discourage to use when the babies get 3 kilograms of weight.
Shift him to standard, yes. Standard.
Because of metabolic programming and like that, they can pass to obesity, especially in those for small for gestation baby. A second, a question for Professor Yasmine about ideal age of complementary feeding introduction. Same question about exclusive breastfeeding till how, and we continue breastfeeding for how long?
I really can't answer this question in the presence of Professor Flavia with all the position papers of the ESPGHAN and all the research that's done.
So we'll shift, we'll make a shift for this question.
Oh, come on, Yasmine, you should have answered. I mean, you are absolutely perfect in shape to answer. Okay, position paper for us, as can say that winning time it's from 17 weeks to 6. So at 4 to 5 months of age, you start winning, and breastfeeding is strongly encouraged to continue until 1 year of age, even 2 years of age, with the weaning, with the solid food. So
complementary feeding,
at least 1 year continuous breastfeeding from 17 to 22 weeks of age, starting weaning food, solid food.
Okay, question for Professor Flavia about cow milk protein allergy formula. It's high caloric formula, and we continue to use this formula with normal weight and height babies. What's your recommendation?
The cow milk allergy formula have to be used in the baby affected by cow milk allergy. When the baby, it's not a problem of calorie, it's a problem of difference in protein. So it's not a matter of calories. So you have to use this formula when the baby is affected of allergy, because the baby is not growing, because the intestine is not doing a proper absorption. So inadequate absorption of the calories. So it's not a matter of calories, but a matter of restoring the intestinal permeability.
Yes, during the panic of COVID-19, another question for you about, is there any rule of prebiotics or probiotics in COVID-19?
This is the question. No, any rule so far, any rule.
Yes, if you'd like to add, Professor Yasmine, because of the panic of COVID-19 now.
Okay, the panic, we will take the prebiotics, the probiotics, the vitamins, everything just to face the panic. Yet there's no evidence. Prebiotic, they enhance, it has proven to enhance immunity and gut functions, probiotics as well, but there's no solid evidence, so no role in COVID.
We need to minimize questions because Professor Flavia tends to sleep. Yeah.
Yes.
It's the time to sleep now.
Yes.
Now, just a few questions. We will continue. Just 3 or 4 questions. One, Professor Yasmine asks about foods which are rich in zinc. You said that zinc deficiency is a problem. So he asks about foods that rich.
The food that are rich in iron are also rich in zinc. This is why we are facing in our country deficiency in both. So it's there in the poultry and the meat products, the fish products. So the expensive animal protein.
Yes. Another very important question.
Nuts, which is also expensive in our country.
Okay. Very important question about mothers who are on keto diet. Many mothers now doing keto diet. Is there children who take breastfeeding need to take any supplements? Professor Flavia?
Well, this is another crazy things that is going on this keto diet. If the baby is breastfed, generally, the mother should have complete nutrition. If they are going to this keto, I don't think that, maybe I'm not aware, but I don't think that there are any studies that show how the breast milk is changing on the mother of keto diet. I'm not aware, at least, that are any studies. So I cannot answer scientifically to this question.
Yes, Professor Yasmine talks in many lectures about keto diet. You have any ads about?
I really talk about therapeutic ketogenic diet in epilepsy, for example.
Yes.
But the trending keto diet nowadays, I wouldn't advise a breastfeeding mom who should have complete nutrition and complete macro and micronutrients to go on a diet that is not healthful, because the keto diet lacks carbohydrates, it lacks fruits, it lacks vegetables. So she will be deficient in vitamins if she's not properly supplemented. The ketotic state that the body is in, we don't have research or evidence if it's transferred in breast milk and the effect on the brain cells in her baby. So besides, if you're on a keto diet for weight reduction, I would advise really strict supervision from a doctor, and this doesn't happen, so no way.
A question for Professor Yasmine about, we haven't in Egypt milk fortifiers. What can we do for continuation of breastfeeding for such babies without fortifiers? What we can add?
Well, I will, these are really good questions. I believe that we will have fortifiers this year in the Egyptian market, inshallah. But fortifying breast milk, we use other sources of fortification, like the high-calorie formula. Sometimes is used as a fortifier. Sometimes we use the high carbohydrate, high fat, and no protein formula. Another formula we use as a fortifier for breast milk. The common use of that I believe have hospitals of fat and of sugars as a fortifier of breast milk, I really don't encourage.
Thank you, Professor Yasmine. Another question for Professor Flavia about a baby delivered 2.6 kilograms. He is doing very well without diarrhea or vomiting. his age is 2 months and he is still 2.6 kilograms.
This is a clinical case, cannot answer, I'm sorry.
Also, what's better, Professor Flavia, what's better is pre or probiotics added to milk formula?
Sorry, once again?
What's better, pre or probiotics added to milk formula? Or both?
Prebiotic or probiotic have a target, so it depends what you want to achieve with the formula.
Yes. Professor Yasmine, about iron supplementation, can it improve appetite in patient without anemia or iron deficiency?
Okay, we have
multivitamins.
If he's not iron deficient, we have the routine supplementation in our population because we are a population with this burden. So all children should be supplemented, and even if with normal hemoglobin and normal iron stores, they have to take 3 months at least every year prophylactic iron supplementation.
Yes. For a question for Professor Flavia about patient with congenital heart disease. Which characters of formula used for such patients?
There is no rule. It depends how is his intestine, how is the calorie intake. It's case to case. Generally, this heart disease has to be considered in the chronic illness. So you maybe need a formula with a high density calorie if the baby cannot have so much quantity. So it depends.
I think it depends also on the type of congenital heart disease. Is it cyanotic or acyanotic?
Not the type of congenital heart disease, but just of the condition of the baby itself.
Yes.
Because you can have different stable or unstable situations, so it depends.
Okay. Professor Yasmine, about introduction of complementary feeding for patients with cow's milk allergy.
Okay, a patient with cow milk allergy is a child like any other child. He has to has proper introduction of complementary feeding at the right time, the right amount. We just eliminate the dairy products. And I don't know if Dr. Flavia will add to this.
Yes, it is the last question, so we will take the answer.
Don't forget just to add the calcium and vitamin D supplementation, and he will just have normal progression about the types of food, fruits, vegetables, proteins, with the texture progression. Everything should be as a normal child, except that we are eliminating dairy products.
Okay, Professor Flavia, you want to add?
No, I'm agreeing.
This answer? Yes. Last question for Professor Flavia about when to use hydrolyzed formula or intact protein formula. Difference between hydrolyzed and intact protein.
The hydrolyzed milk formula, again, you can use it when you have cow milk allergy. It was used in the past for transit time, to reduce transit time, but the results are controversial. Some premature baby are using, but basically hydrolyzed milk formula is for cow milk allergy and all their manifestations.
Thank you, Professor Flavia. Thank you, Professor Yasmine. Very interesting day. Actually, I get many benefits.
Flavia. It was a pleasure.
Knowledges.
Thank you,
it's a great pleasure to be with you.
You are a great speaker and a great scientist.
And I'm actually honored to be a moderator for.
Thank you.
Thank you for all. Finally, I would like to express my deep thanks and appreciation for Dr. Flavia for wonderful and useful talk as usual. And welcome, Dr. Flavia, at any time.
It was an honor having her amongst us.
And also,
my pleasure.
I would like to extend my deep thanks to Dr. Yasmine Gamal for
Dr. Yasmine, Dr. Zannoun. We will go to Luxor with Dr. Zannoun next year. Professor Flavia will go with us.
Yes, we will invite Professor Flavia in. Thank you, Dr. Osama, for great moderation as usual.
Thank you, Chair. Thank you. Bye-bye. Good night.
Bye. Good night.
Thank you, Professor Flavia.
Bye.
Bye. دكتور ياسمين، احنا طبعا يعني اضطرينا معظم المحاضره ان احنا نتكلم باي انجلش او بيور انجلش، ولكن الناس معذباني معاهم يا دكتوره ياسمين.
يعني عربي بقى دلوقتي.
احنا نتكلم انجلش او تتكلموا.
احنا هنقلب محاضره ثانيه للدكتوره ياسمين بس نص عربي ونص انجلش يعني فاحنا بعد كده
يعني لو الناس اتكلموا.
والله الف شكر للاطباء اللي قعدوا معانا لغايه دلوقتي يسمعونا، ويا رب ان شاء الله يكون علم ينتفع به.
والله ما شاء الله عدد كبير، يعني انا اول مره ابقى موجود، عدد كبير ما شاء الله يعني موجود، وعدد الاسئله لو كملناها كنا قعدنا لحد الصبح يعني. ف انا اول مره يعني ابقى مع الايجيبشن اكاديمي، ودي حاجه تسعدني كثيرا يعني. اخويا العزيز دكتور محمد، دكتور وائل، دكتور محمد صلاح، يعني يا رب اتمنى لهم التوفيق. وفعلا هم يعني نجحوا في ان هم تو فيل ذا جاب فعلا في الكونتينوس ميديكال اديوكيشن في الفتره الصعبه، لان هم طبعا مجهود رهيب اللي عملوه عشان يقدروا يعني احنا مره معاهم وتعبنا يعني. هم كل يوم في هذا التعب يعني.
قالوا في ميزان سنتكم.
ربنا يبارك فيكم يا رب يعني. واحنا والله اثناء الويبينار بتلاقينا بنجهز وتليفونات، وعشان الويبينار بتاع يوم الاثنين وبتاع
والله انا يوم واحد حضرته معاكم يعني، فكتر خيركم يعني. طبعا انا شاكر ان اديتوني من زمان، كان نفسي ابقى مكان الكابتن لطيف كده بذيع ماتش من ساعه ماتشات الكوره. فانت اديتني الفرصه مع اختي العزيزه الدكتوره ياسمين، اللي انا ببقى سعيد ان انا ابقى موجود معاها وبستفيد من محاضراتها. وفعلا يعني التيم كله بتاع عين شمس انا باشرف يعني ان انا ابقى موجود معاهم، لان ليهم ايادي بيضاء علينا ودايما حريصين على تقديم العلم، ودايما بيبقوا موجودين معانا. فانا بعود واشكرهم تاني يعني. وان شاء الله اتمنى دايما التوفيق الايجيبشن اكاديمي في بيدياتريكس، اتمنى التوفيق ان شاء الله لجميع الجامعات المصريه وجامعه عين شمس، وان شاء الله دايما يا رب كده يدينا الاجر والثواب في تقديم المعلومه ان شاء الله.
بالتوفيق جامعه اسيوط ووحده التغذيه في جامعه اسيوط، بالتوفيق ايجيبشن اكاديمي اوف بيدياتريكس. تصبحوا على خير.
انا بس في النهايه يا دكتوره ياسمين انا عاوز بس اقول ان احنا برضو ما طولناش، لان الناس انتوا عارفين ان من الساعه 1 كان في بارل ايفنت موجود.
النهارده يوم رهيب.
فبصراحه كتر خير الناس اللي متابعانا لغايه دلوقتي، فيمكن ده يعني لود عليهم، وربنا يبارك فيهم يا رب ويكرمهم، الناس اللي هي عاوزه تلهف على العلم وتتابع العلم. وعشان كده مش هنطول عن كده يا دكتوره ياسمين، كفايه عليهم قوي كده.
تحيه للاطباء. انا بقرا هو البانيلست في بغداد وفي صلاله سلطنه عمان وشرفتونا والله.
ما شاء الله يعني من كل الدنيا. ربنا يكرم ان شاء الله، دايما موفقين ان شاء الله.
يبارك فيكم. وزي ما اتفقنا وهنعلن ان شاء الله على اول 8 او في اول ايام من 8 باذن واحد احد عن حاجه ان شاء الله هتبسطكم جميعا، وحاجه تسعد كل الاطباء المصريين والعرب باذن الله.
ان شاء الله موفقين.
تصبحوا على خير جميعا.
تصبحوا على خير. شكرا.
اخر حاجه، في حد لسه باعت اهو بيقول التسجيل وما بتسجلوش الويبينار لمرات كتيره. هنقول ان الويبينار يا دكتور اسامه متسجل وبينزل على قناه الاكاديمي والجمعيه.
انا نفسي بسمعهم على طول على القناه يعني الفيديوهات. يعني دايما لو حاجه فاتتني تاني يوم بصراحه انا حريص على الحاجات يعني ما شاء الله كلها ليكتشرز بتبقى جميله. فالفيديوز موجوده في خانه الفيديوز يعني كلهم بيبقوا نازلين ان شاء الله يعني.
ان شاء الله باذن الله. ومتشكرين لكم جميعا ولك يا دكتور اسامه بالذات على يعني الاداره الرائعه والجميله دي للويبينار.
انا بسعد يا دكتور زنون ان انا اكون معاكم في اي حاجه. يعني انتوا اخوات اعزاء وربنا يعينكم في المجهود اللي بتبذلوه ده. متشكرين خالص. شكرا
لك يا استاذ.
شكرا يا فندم. تصبحوا على خير. مع السلامه. مع السلامه.